In the improvement model, we're really focusing on improvement of care. You have a flexible hypothesis, it changes as learning takes place. You run charts or Schuhart control charts, and you do it daily, weekly, or monthly. In accountability, you're comparing, making choices, and you're providing assurance. There's really no hypothesis and there's no change in focus, and you do it over longer periods of time. Then in research, you're really trying to build a body of knowledge, and you have a fixed hypothesis, and you're running statistical tests, and you're doing it at the end of the project. But the bottom line in my daily life, it's kind of like trying to drive my department as a car going down the road looking through the rearview mirror. Yeah, and that doesn't work for me in the here and now. I need to have confidence in some way that what I'm doing is likely to be a positive change, and that I'm not going to implement something involve large amounts of resources or numbers of people only to fall flat on my face because it really didn't turn out the way we thought. You know, and I can give you some examples of that. One is that we were going to implement a physician referral form, and some of the staff got together and they made up this form that they thought was great. And when we went to implement it, we realized that they hadn't talked to the nurses that would have to adapt it. You know, I'm looking at it and they're saying, you know, this isn't going to work for us. We need to do this and this and this. More extreme is we implemented an electronic health record system that cost us hundreds of thousands of dollars that we were never able to successfully and reliably bill through, much less collect data on outcomes or enter it in electronic health record. So, you know, it became a really critical issue for us that we did it. So we wanted to look at gathering information. And sometimes it brings immediate and surprising knowledge. So as we were looking for an answer, we needed to look at what we wanted to do. And I was introduced to the improvement model. And in general, at the end of the story, what I have to say is I've seen more meaningful change in the 2 years that we've been involved in that, and more culture change than I have ever seen using any other method to manage change. And the extreme amount of work that it took on part of all of us is well worth the effort in my setting and context. Right now, there's about 25 counties that are involved in some way in using a model for improvement. Coming from an old researcher, I wasn't sure, but I was desperate. And I have to say, I've become a believer. I might disagree a little bit with our consultant about the purpose and value of evaluation and research and using that method, but I've also become convinced that by use of a registry or other methods, doing the PDSA cycles and using that data to feed evaluation and research and outcome measures is really the way to go. It really contributes to the overall quality improvement, but also for us being confident about what our outcomes are. I wanted to show you this run chart. We're in the midst of trying to pilot and set up standards for the registry that we're using. It happens to be Pexis. It was cheap for us to use, and it was doable, so that's the one that we're using. I'm sure there are others out there. But a week or so ago, when they were running one of the PDSAs, our peer support staff person came into my office waving this run chart. And he said, Karen, look at this. What are we going to do about this gradual weight gain that Dan is experiencing? You know, if the clinician was looking at this in a narrative and they were just writing it down, they just think that his weight was just fluctuating up and down a little bit. But this is a gradual weight gain. This is a pound a month. And what are we going to do? And I said, well, what do you think we ought to do? You know, and then he went on to say, you know, if my clinician ran this report and this report and this report, I think we might be able to see a pattern that would help me manage my bipolar disorder. I said, bingo. You know, that's what we want. And when the clients and the family members and our staff and our other partners sit down to run this PDSAs, at the end of the day, when they've run enough cycles and they have confidence that, yeah, this is something we want to do, it's theirs. It's not mine saying, you need to make this improvement. They've already started it and they're ready to spread it. And the other thing that I've seen is as we establish shared measures and behavioral health measures and incorporate them into the registry, one of the things that I really like is that when we implement a best practice and we have measurements of that, the registry drives that data collection. It helps provide an outline for what needs to occur in the session, and I don't have to be going back and reminding them, and I can go into the encounter notes for the clients and I can see exactly if they made the measurement or not. And I don't have time to do that, and I can't tell you how many times I've said, remember, you need to collect these measures. And they say, yeah. Did you give us that? And I say, yeah, here it is again, and collect them. Do we really have to do we have to catch up on it or whatever? With this, they keep the counter note open. It tells them, and it shows up in red if they haven't run it. So it monitors adherence to best practices, but it also gives them an easy way to record it and an easy way to run a single subject run chart where the client and the clinician can see the progress that they've made on the measures that they're collecting for them. I wanted to show you a copy, went the wrong way. This is an annotated time series of running tests. These were efforts that actually Lassen was making to increase the number of clients that they had a PCP indicated for and enrolled. And so it shows kind of where they were and when they met their goal, and you can annotate this on what changes you've made. So as you're tracking it through, you can see that. I think it's obvious in terms of how that might be aggregated between counties or across the state. This is a copy of tracking multiple measures in kind of a dashboard, and how you can just kind of look and see where your clients are, and what it might look like if you were comparing across counties or programs. So I wanted to share with you a little bit of some of the basic learning that we've come up with from our testing of the registry. And I kind of referred to this before if we keep the registry screen open, I might go back to say we do have an EHR, but I've yet to be convinced that it is simple or as usable as this. The producers of EHRs will tell you it is, but what they don't tell you is that in the narrative, many of the things are lost and they're not unsearchable fields. So, they're trying to make improvements, but you put in a request for an improvement, it may take you 2 or 3 years. I don't have 2 or 3 years to wait. for that. And so, you know, what I am working on is getting a report that will download what information is in the EHR, which is very limited, into the registry, so we don't have to do redundant entry of data, and then we enter what it isn't there. But the clinicians can easily then run what reports they need to for the client's purposes at the time, but it also, again, drives the best practices in the data collection. I'm encouraging them right now. What we're testing is keeping open. They have dual monitors on their screen. They can keep them both open if they need to, and they can enter the data. One of the things that we found is that clients gave a real positive response to seeing their own data reports and run chart. And some clients were even making the connection, oh, you know, I need to correct this. Or, oh, see what happened here. This is what's going on. So it gives an opportunity for dialogue and to build their confidence in planning for their own wellness. And also, when our clients experience the success in running and using the individual client reports and the positive feedback from both the clients and their primary care physicians in our care integration, of course it increased their buy-in. It was theirs.